There is one treatment that works brilliantly for spider veins on the face. And there's one treatment that works brilliantly for spider veins on the legs. They are not the same treatment, but here's what's interesting. Some of the best results I've seen, and what the published literature now confirms, comes from using both of these treatments together on the legs at the same time. And the patients who benefit most are the ones with exactly the kind of veins that have always been very challenging and the hardest to treat. Stay with me, because this changes how you should think about treating spider veins on the legs. There are two gold standards. On the face, radiofrequency thermocoagulation at 4 MHz is the treatment of choice for fine telangiectasia, the tiny red veins across the nose and cheeks. The reason is pretty straightforward. These vessels are too fine to inject with a needle, and what's more, sclerotherapy on the face carries real risks: pigmentation, necrosis, and, in rare cases, visual complications. There's been a report of blindness after sclerotherapy on the face. So instead, we use a fine insulated needle. We apply a brief pulse of high-frequency current to the vessel. The vessel coagulates and it disperses and disappears. Radiofrequency thermocoagulation on the face is clean, precise. There's no injection of sclerosant. There's no medication entering the circulation. It's well established. Jean-Marie Chardonnot has published data on thousands of facial vein treatments using this approach with excellent cosmetic outcomes. Microsclerotherapy on the legs. Well, on the legs, the picture is different. Leg spider veins, also known as telangiectasias, and reticular veins, also known as feeder veins, tend to be larger, more numerous. The spider veins are fed by feeder veins deeper in the skin, and they're under somewhat higher pressure than facial veins. For these, microsclerotherapy, which involves injecting a very small volume of sclerosant directly into the vessel, has been the gold standard for decades. It works extremely well for reticular veins, those bluish feeder vessels, typically 1 to 3 millimeters in diameter. And it works well for spider veins. You can inject them directly. Often they're large enough to inject very reliably. The Cochrane Systematic Review, published in 2021, looked at 35 randomized control trials with over 3,500 patients. And that Cochrane review confirmed that sclerotherapy remains the most effective single treatment for leg telangiectasias overall. So why would you add anything else? Well, here is where it gets interesting and where clinical reality diverges from the textbook and from established practice. Not all leg spider veins are the same size. Anyone who has been doing this for more than a few months knows that there is a subset of leg telangiectasias. The very finest ones, typically less than 0.5 millimeter in diameter. They are genuinely difficult to treat with sclerotherapy alone. First, they're often simply too fine to inject reliably, particularly amongst people who are not very experienced. Getting a needle tip into a vessel less than 0.5 millimeter across in the superficial dermis is technically challenging, even for very experienced practitioners. Miss the vessel, and you're injecting the sclerosant into the dermis rather than the vein. You'll get a bleb. That means the risk of inflammation, blistering, scabs, and at worst, skin necrosis. Second, when you do inject successfully into a very fine spider vein, the outcome isn't always ideal. Very fine spider veins can develop hyperpigmentation, iron staining from hemosiderin, and as the sclerosant destroys the endothelium, you can get a lot of inflammation and neovascularization. That means a significant proportion of patients develop telangiectatic matting, new tiny vessels that form around the treated area. And sometimes they are more cosmetically a problem than what you started with. Thirdly, those fine spider veins fed by reticular veins under pressure often recur when you treat the spider vein without adequately addressing the feeder. So you have a cohort of patients, and it's not a small cohort, where sclerotherapy alone leaves something on the table. It's not always very effective. You treat the reticular feeder veins well. You treat the larger and medium-sized spider veins well as well with sclerotherapy. And then you're left with clusters of very fine red veins that are either too small to inject safely or that simply don't respond as completely and as satisfactorily as you'd like. These are the patients who come back after their second or third treatment. They're often asking why those particular veins are still there. This is where the combination approach becomes very compelling. And I have to say, many of my colleagues have also started using combination treatment. So it's not just anecdotal. And there's a logic to it as well. Reticular veins, the feeder vessels, are 1 to 3 millimeters across in the mid-dermis, and they're under moderate venous pressure. This is the sort of vessel which is ideal for sclerotherapy. You inject a small volume of sclerosant. It could be foam or it could be liquid. My preference is liquid. It contacts the endothelium. The vessel responds by shrinking and dispersing, and the vessel is essentially destroyed, and it obliterates over the following weeks. Sclerotherapy is doing exactly the job it's designed to do. Radiofrequency targets the finer vessels. The fine spider veins fed by those reticular veins are a completely different target. The very fine ones are under 0.5 millimeter. They're superficial, low pressure. It's very difficult to reliably get a needle into them, but they are exactly the right size and depth for radiofrequency thermocoagulation at 4 megahertz. The needle pierces the epidermis and sits on the vessel. A brief half-second to 1 second pulse of current treats the vessel wall to a coagulation temperature. The vessel wall denatures. Obliteration of the vessel follows, and the vein is absorbed completely. There's no injection, there's no sclerosant in the systemic circulation, and there's a very low risk of hyperpigmentation at this vessel caliber. So you're using each modality at its optimal vessel size range. You're not forcing sclerotherapy into vessels where it carries a disproportionate risk, and you're not using RF on the feeder veins. These actually respond better to sclerotherapy. There's a division of labor based on vessel caliber, and it makes biological sense too. Diken et al. 2021 published a randomized control trial in the Journal of Phlebology. They specifically designed this trial to ask the following question: does adding radiofrequency thermocoagulation to liquid sclerotherapy improve the outcomes compared with sclerotherapy alone? This was a pilot randomized trial. Patients with leg telangiectasias were randomized to one of two groups. The first group, sclerotherapy alone. The second group, sclerotherapy plus radiofrequency thermocoagulation. Although it was a small study, the results were clinically meaningful. The combination group showed significantly better cosmetic improvement scores. The rate of hyperpigmentation, one of the most common and frustrating complications of sclerotherapy, was lower in the combination group. Patients in the combination group needed fewer treatment sessions to achieve their cosmetic goal. And, importantly, there were no additional complications in the combination group compared with sclerotherapy alone. The combination didn't add risk, it added benefit. So what exactly does pilot mean here, and why does it matter? Well, a pilot randomized controlled trial is a smaller trial designed to test whether the study design is feasible and to generate preliminary data for a larger definitive trial. It's not meant to be the final word. The sample size is small. The statistical power is low. So the results, whilst genuinely encouraging, should be considered hypothesis generating rather than practice defining on their own. But here's the key point. This is, so far, the only randomized trial that has directly tested this question. It is of the highest level of evidence we currently have, and it points in a consistent direction. Combination therapy is better than monotherapy for this indication, without any added risk profile. This is a meaningful finding, not a reason to change every patient's treatment plan tomorrow, but absolutely a reason and a justification for what we teach in our mentorship program. My colleagues have already incorporated this approach, especially for those patients with very fine spider veins that haven't responded fully to sclerotherapy alone. In some cases, a sequential approach is used, particularly in patients with extensive reticular veins. In other cases, combination treatment can be offered in the same session, which is ideal for a mixture of spider vein sizes, or if the patient prioritizes fewer visits. But there is an evidence gap. The Cochrane review I mentioned earlier, the 2021 review of 35 trials, did not include any studies specifically of RF thermocoagulation as a comparator in its primary analysis, because those trials simply didn't exist at the time of the review. That's an important gap in the literature. It means this combination approach, despite its biological logic and the early randomized trial evidence, hasn't yet been tested in large definitive trials. That study needs still to be done. But let's be honest here. Given how difficult it is to plan and organize large RCTs and how expensive these large RCTs are, I really doubt whether such a study will ever be done. What I can say is that clinical practice is definitely racing ahead of the clinical evidence. Many experts have already started using RF thermocoagulation in combination with microsclerotherapy in the treatment of leg spider veins. And we teach this in our courses now. What does this look like in real clinical practice? In a typical patient with leg spider vein disease, spider veins with visible reticular veins, the approach is relatively straightforward, and I call this option 1. First, use sclerotherapy to target the reticular feeder veins with 0.5% polydocanol. Liquid or foam? We prefer liquid. Treat the larger spider veins in the same session if you can get a needle into them with 0.25% polydocanol. Then, in a subsequent session, usually 4 to 6 weeks later, when the inflammation response has settled, use RF thermocoagulation at 4 MHz to address any residual fine veins that either didn't respond to sclerotherapy or were too fine to inject initially. The sessions are short. The RF phase for residual fine veins typically takes 10 to 20 minutes maximum. The patient doesn't need to wear compression for either of the treatments, either the sclerotherapy or the RF component. And the combination addresses the full spectrum of spider vein disease, from the feeder veins to the finest vessels, in a way that neither modality achieves alone. Option 2. Sclerotherapy and RF thermocoagulation in a single session. This has the advantage that everything is treated in one session with fewer visits. The downside is that the session is longer. The combination of RF and sclerotherapy addresses the full spectrum of C1 disease that no other single modality can. The ability to perform microsclerotherapy and RF thermocoagulation is the basis of a comprehensive, profitable cosmetic vein practice. I'd like to know what you think. Are you already using combination approaches in your practice? Are you still using sclerotherapy on its own and relying on repeated sessions for the very fine veins? Leave a comment below. I read every single one, and I'll try and get back to you as soon as I can. Tell me your experience with fine veins that don't respond well to sclerotherapy. Tell me if you've tried RF as an adjunct. Tell me what questions you have. This field moves forward when practitioners share what actually works in their clinic, not just what looks good in a trial protocol. If this video was useful, consider subscribing. That way you won't miss my next video. And if you know a colleague who's wrestling with fine vein problems, share this video with them. It might change how they approach their next patient. I'll see you in my next video. Thank you for watching.